Sandeep, we are ready?
Oh, we are ready, sir.
Can I start?
Yeah, please.
Okay. Hello, everyone, and welcome to this webinar on hip arthroscopy. I'm Dr. Shreyash Gajjar, and I work at Kokilaben Dhirubhai Ambani Hospital in Mumbai. Firstly, I'd like to welcome and acknowledge the Indian Arthroscopy Society team, our dynamic president, Dr. IPS Oberoi, Secretary Dr. Swarnednu Samanta, and the entire executive committee members, including the web team who are really working tirelessly in these challenging times and doing a wonderful job as far as these webinars and the education goes. Hip arthroscopy, as we all know, has significantly progressed in the last decade because of better understanding of the joint vis-a-vis imaging, and also knowledge, skills, and the outcomes and these international meetings and webinars. So I'm very fortunate to have an expert group of people as my co-faculty, and I'd like to welcome them all. Firstly, I'd like to welcome Dr. Thane Munting from Cape Town, South Africa. Cape Town is one of my favorite places. I really loved it. Dr. Munting is a pelviacetabular hip surgeon and also does some knee surgery. And as he mentioned, he does everything from pediatric to geriatric. And in today's day and age, it is more under the banner of a hip preservation surgeon rather than just hip arthroscopy. He's also been a founder member of the South African Hip Arthroscopy Society and was its chairman from 2015 to 2017. He sits on the professional advisory board of the hospital he works in and has helped form and develop the Cape Town Sports and Orthopedic Clinic. So welcome, Dr. Munting, on behalf of the Indian Arthroscopy Society. I'm also privileged to have Dr. Prasad Gourineni, who is a fellow of the American Academy of Orthopedic Surgeons. He's an associate professor at the University of Illinois in Chicago, and has also built up a hospital here in Tirupati and heads the Amara Hip Preservation Center. He has an interest in pediatric and young adult hip preservation, arthroscopy, and osteotomy. So welcome, Dr. Gourineni. And also I'd like to welcome my co-faculty from Mumbai, Dr. Vijay Shetty. Dr. Shetty is a consultant orthopedic surgeon from LH Hiranandiri Hospital in Powai, Mumbai. He has done advanced fellowship in hip and knee surgery from Cambridge under the mentorship of Mr. Richard Willer. He's also vice president now of the Indian Arthroscopy of Sports Medicine, general secretary of the Indian Biologic Orthopedic Society, treasurer of the Indian Cartilage Society, and he's got a number of accolades on his sleeve. So really an excellent faculty to cover this growing topic in our country. Now, to just share some housekeeping rules, Sandeep is our webmaster, and I'm sure he's muted the audio and video of all participants. We will commence the talks first, and the question answers and the discussions will be held at the end. And Dr. IPS Oberoi, our president, has kindly agreed to preside over that. And is Dr. Swarnednu Samanta, our secretary, has he joined yet or not?
He'll join in 2 minutes.
Join, then we will have him later on in the discussion.
Yes, sir.
So without, I would just request Dr. Vijay Shetty to please share his presentation and talk about indications, patient selection, and also a bit about lateral position hip arthroscopy. Dr. Vijay Shetty.
Hello?
Yes, Sandeep, we are all audible.
Yes, sir. Please go ahead. Start the slideshow, keynote.
Can you see my screen?
Yes. Please play it, sir. Play.
Can you see now?
Yes, sir.
Yeah.
Yeah.
So,
Yes,
okay,
sir.
I'm on the
Please go
first
ahead.
screen, yeah? All right, okay, welcome guys. And I met a couple of them. And thank you, Shreyash, putting up this show. Sandeep and IPS, all old friends. And my colleague from South Africa, welcome. And must be morning hours for you, and Dr. Prasad as well. I work in Mumbai. I did the background is my HIP fellowship with Richard Wheeler, my guru and mentor, whom I'm in touch with even today. A fantastic teacher and a mentor who actually takes you through what you can do. What you do in a year is probably equivalent to what you do in 4 years of your training. So that's how he trains you. It starts at early morning at 4 o'clock. Now, before I take you through, my topic is very, very simple, and thanks to strangers, Shreyas. I want you for the viewers and for the young audience to look at this book that was published just about 2 years ago. This is sponsored by International Society of Arthroscopy, and you have these three big names there: Jose McCarthy, Phil Noble, and Richard Wheeler. And I had the privilege to write a chapter in this book on hip arthroscopy in India. Obviously, there are people who are interested in knowing what's happening. In fact, we are at the moment as we speak, we are trying to do a survey of those surgeons who are doing hip work in our country. So for me, this is fascinating, and I think this is one of those lines that Richard Wheeler used to always tell me, that how he started his career as a hip surgeon. The story of hip arthroscopy, in fact, the evolution of hip arthroscopy on this earth is one of innovation, experimentation, and ultimately success, which is a fantastic line. I keep remembering this all through whenever I have a complicated cases. I say this because you go back, I'm going to take you through this beautiful story of the beginning of hip arthroscopy, and we go back to where we didn't have anything in hand, where we had these people talking about hip arthroscopy and saying it is not possible. It is not possible at all. In fact, this gentleman from New York in 1931, almost 90 years ago. I mean, this statement you will see in almost all readings, all types of articles, or especially review articles that you see this statement from him. It is manifestly impossible to insert a straight needle between the head of humerus and the acetabulum, i.e. is a ball and socket joint. So that was 1931, and then in 1991, which is almost 6 decades, there was nothing that was happening at this point. So Jim Glick in 1991, he wrote an article saying we still have problems diagnosing some of the hip conditions, and he mentioned that almost about 4 out of 10 of hip conditions they go undiagnosed, which means about 4 of them, especially in sports, they don't get recognized, they don't get diagnosed, and we don't know what's happening, and people as a result come out of sports. Then 1997, Tom Bird, you would have seen him in many of these conferences, tall man, and he wrote this article saying that this is, say, 1997, which is like almost 30 years old, nearly 40. And arthroscopy surgery is now, which is like late 90s, is now a well-established procedure. I think this is very important. And then came Jose McCarthy's paper in 2005, saying that it is now possible to access hip joint, and we can assess evolving series of conditions, many of which were previously unrecognized and undiagnosed, and they were left untreated. So it's now possible for us to get into the joint and see what's happening, and you can get a reasonable diagnosis. And this was very important. And I think when I say this, again, I would highlight on this slide, you see this area, about 6 decades, nobody was interested. And you see early 90s, some activity there. And again, this is the time when I think a lot of these big names that we have here today actually started doing work and publishing around this area. And I think the last 2 decades, if you see, have actually seen steep rise in publications and work and indications and everything else on hip arthroscopy. Why this has happened in the last two decades? I think it's because of the advances in technology, in so many things, techniques, investigations, and all that. So before Shreyash shuts me up, and I just want to get back to the scenario where we started. So that's because we have this X-rays, arthrography, CT scan, MRI scan, a lot of these gadgets available. Now, I don't want to go into the details of it, but some of these things are very, very important, especially for those young surgeons who want to take hip arthroscopy in their practice. See, a simple X-ray, but there are so many things happening in this X-ray. This X-ray is very likely to go as a normal X-ray for most orthopedic surgeons, but if you really look into it, you see there is a sharp ischial spine, and there is a bump there, and there are so many things happening. This is obviously a combined femoroacetabular impingement. I mean, for a diagnosis, you don't really go far beyond this. And then you go into the CT scan, and you see there again a 3D image, lateral view of the right hip joint. You see there is a prominent anterior inferior iliac spine, and there is what is called os acetabulum, which was never diagnosed before unless you have this CT scan in hand. And again, then you come into MRI scan, and I'm only touching to the basics of this. And you see some of these things. See, there is an intralabral ossification within the labrum, and just at the junction of chondrolabral junction. And you see there is something that may go unnoticed, which is synovitis of the hip joint. And again, I think very important, MRI scan actually detect these areas which are problematic in the hip joint, especially chondrolabral junction. This is very, very important, I think, in sports medicine. One of those things that really go undiagnosed in hip joint is pigmented villonodular synovitis. I mean, diagnosis is not that difficult, but this is one of the very, very popular indications for hip arthroscopy, especially in our country, in India. Now, again, in techniques, I mean, this is fantastic. This is, if you see on your left, those who have visited Cambridge before 2006, you would have seen this gadget in Richard Wheeler's OT or room, and he devised this. This was fantastic. I used to arrange this as a fellow before he started the operation, and this is all mechanical, custom made, in fact, homemade in Cambridge. And then in the late 2000, Smith and Nephew came up with this device, which is fantastic, very easy to operate. And of late, we have this fabulous gadget, which is very, very sophisticated, just not for hip arthroscopy, for everything on hip surgery. So when you come down to the indication part of it, I think this lecture is mainly for those who want to take up hip arthroscopy in their practice. I think for me, it's just 2 aspects of hip. You have the central compartment and you have the peripheral compartment. The central compartment, as I said, is intraarticular. The peripheral compartment largely is extraarticular. I think our youngsters have to remember just these two lines. And again, I'm not going to go into the details of this. This is all available everywhere. I think if you see a question in your final exam paper, you'll have to probably by heart this and write down. But I think the point was just to give you a rough idea as to these are some things, some conditions that you can actually identify doing hip arthroscopy and even treat them. But having said that, I maintain again it depends on the type of surgeon you are, the number of operations that you do, and the type of experience that you have. So for somebody who's done thousands of hip arthroscopy, I think the indications are really big, and somebody who's doing some few numbers, then the indications are not that great, but which is very important. So when you look at the extra-articular pathology, this is one slide I inherited from Richard Wheeler again. He was doing gluteus medius release extra-articular doing hip arthroscopy. And again, there is something that's called trochanteric bursa, which is also being dealt with these days through hip arthroscopy. I think in our country, again, especially when you're starting hip arthroscopy, I think for loose bodies in the hip joint is a perfect indication for hip arthroscopy, especially for young surgeons. One of those rare slides that you'll see, a lipoma. This is again courtesy Richard Wheeler, lipoma within the hip joint. You see a beautiful picture of swelling in the corticoid fossa of the hip joint. Again, the indications can be extended further. This is hip arthroscopy performed on a painful THR. Again, Richard Wheeler's slide here, and you see there is a wear in the neck of the femoral component. And having said that, is there a contraindication for hip arthroscopy? Plenty. I think, again, if you can't do an operation for a particular condition, it becomes a contraindication for that particular surgeon. This is full stop. I think that's where we are at this point. But if you are a surgeon, high volume surgeon, but things can get better and better, there is absolute contraindication where, in fact, excuse me, if it is advanced osteoarthritis, obviously you can't get into the joint. I think you'll have to be careful. And ankylosis, for example. And I just want to highlight on this thing, greater trochanteric impingement. Again, the new block in town, especially in youngsters, you'll have to do pelvis X-ray with full abduction. If you see the greater trochanter is impinging on the pelvis, this is not the one for hip arthroscopy. I think that's a simple test that you should be doing. Relative contraindications, I mean, this is flexible again. A very experienced surgeon probably won't bother, even if it's obesity, moderate OA. But these are the things that we need to remember. In summary, I think it's very important. We need to realize that this is a high volume surgeon's job. The indications are rapidly evolving. Those who want to start the operations on their own should get some fellowship from somewhere, and they should know their ability to perform the hip joint and know their limits. And also, it's very, very important to remember this last line. We need to adhere to evidence-based indications and contraindications. And if you need help, there's this fantastic website of International Society of Hip Arthroscopy, and you can log in there and get answers and help from experts. Thank you for your attention, guys. Thank you.
Thank you, Vijay Shetty, for providing an insight into the evolution of hip arthroscopy and taking us through some indications and contraindications. As he mentioned, a lot of it is already in the books, and he's given a reference. So things like presentation and clinical examination, I'm sure you have plenty of access to. But we can always cover it in the discussion and Q&A section if there are specific tests which the participants or the faculty wish to discuss for certain situations. I'd also like to welcome our dynamic secretary, Dr. Swarnednu Samanta, for joining. Again, these people are working tirelessly and they're doing a wonderful job. So welcome, Swarnednu.
Yes, Dr. Shreyas, this is a great meeting I think we are going to have. You have organized the meeting. We're really grateful to you. You go ahead with the scientific thing, then at the end we'll discuss the questions, whatever is coming. Okay.
Thank you and welcome once again.
Thank you.
Now I'll just share my talk on setup, portals and access. So Sandeep, will I be able to do that now?
Go ahead. You can go ahead, Shreyas.
Yeah, sure, you can go ahead. There is a burning question coming for Vijay. Vijay, how often are you doing an MR arthrogram these days for indications?
I don't do MR arthrogram now.
So you just a plain MRI.
Sorry?
Sorry, IPS, can I just interrupt? Vijay, do you mind exiting your talk because I'm not.
Yeah, you have to.
You have to unshare your screen.
Unshare your screen.
Yeah. Okay, just a minute.
Yeah, that's good. So just a plain MRI, Vijay, you said.
That's correct.
And
Most things you can
another
see now. Yeah, sorry.
Yeah.
Hello?
Yes, can you hear us, Vijay?
Now I can hear you now.
Okay. The question is that do you have any indication?
Sir, we have questions at the end, sir.
So Swarnednu, if I may just request for all the questions and answers and the discussion at the end, which will
Somebody,
just make it very easy.
IPS was asking that question. So Vijay was answering in between. He was not audible. Okay, Shreyas, you can go ahead. Go ahead.
Is it okay? Can I start with my talk?
Go ahead.
Okay, thank you. So as I said, this topic is on setup, portals and access. And I work at Kokilaben Dhirubhai Ambani Hospital in Mumbai. So we very well know that the hip joint is a constrained ball and socket type of joint. It has a very dense surrounding soft tissue envelope and also nerves in its vicinity, thereby making it susceptible to any form of iatrogenic injury. And therefore, proper orientation and a sound technique is crucial while performing this procedure. So broadly speaking, the arthroscopic compartments are divided into a central one, which actually comprises the articular surface of the femoral head and the articular surface of the acetabulum. The horseshoe-shaped cartilage is called the lunate fossa, and the cotyloid fossa is right at the bottom, and it is easily identified with yellow-colored fat. And the ligamentum teres, which you see, is attached right from the base of the cotyloid fossa and the posterior part of the transverse ligament onto the fovea of the femoral head. The peripheral compartment comprises everything which is lateral to the labrum up to the intertrochanteric line. And it comprises of a capsule which attaches to the intertrochanteric line. That capsule midway around the femoral head neck area forms a thickening called the zona orbicularis, and the iliofemoral ligament lies superficial, anterior and superior to it. And this capsule further broadens and spans to insert onto the perilabral area. There is also, with the renewed interest in hip arthroscopy and its wide applications, there is also now a recognized peritrochanteric compartment, which essentially comprises of the area around the greater trochanter and the overlying fascia lata and the peritrochanteric fat. And for certain indications like snapping hip or bursitis, this sort of procedure is performed. And actually, it's like an endoscopic type of procedure because it's not lying within the joint. So when we venture to performing hip arthroscopy, it is important to recognize that a 70-degree arthroscope is quite helpful because, as you can see here in this diagram, it provides a wider view both on the acetabular and the femoral side compared to a 30-degree. And therefore, the user needs to make oneself familiar to ensure that the orientation is accurate to prevent any form of iatrogenic injury and to minimize the duration of the procedure. Also important is fluid management, and typically I use some form of a pump, and also a dedicated hip arthroscopy set is useful because, as we know, because of the extensive soft tissue envelope overlying the bony architecture, the instruments typically are longer compared to the ones which you use in the shoulder and the knee. And also there would be certain handheld or disposable instruments depending on what therapeutic procedure one contemplates. Most importantly are these spinal needles, typically a 17 or an 18 gauge with guide wires for access into the hip joint, and I will talk through it in my subsequent slides. So as far as positioning goes, hip arthroscopy can be performed in the supine or the lateral position. I do them in the supine position. The patient is placed on the fracture table and a generously padded perineal post is used. Thereafter, the pelvis and the upper trunk is moved away from the operative area. And what this does is that it creates the desired distraction vector and prevents any pressure onto the perineum and also neuropraxia of the pudendal nerve. Thereafter, the operated hip is placed in about 25 degrees of abduction, in extension, and in neutral rotation. And thereafter, the contralateral hip is also placed in abduction to make way for the fluoroscopy image intensifier. The advantages of a supine position is the use of a standard fracture table, so it obviates any specific traction type of equipment. It also provides good access to the anterior portions of the hip where most of the pathology resides. And also there is a limited possibility of fluid extravasation into the soft tissues and the abdominal cavity. In comparison, when one positions or uses a lateral position, firstly, the operated leg is placed in a foot holder. Thereafter, it is positioned in abduction, in extension, and in neutral rotation. And as like the supine position, a generously padded perineal post is used to obtain the desired vector and prevent any neuropraxia and pressure onto the perineum. The advantages of using a lateral position is especially in the high BMI patients, where the fat envelope tends to be pushed away because of gravity, and therefore it allows easy maneuverability of the instruments. It reduces the amount of tissue what needs to traverse to reach the joint, and also importantly offers easier entry into the joint in those patients with the anterolateral acetabular spurs, as introduction of the posterior portal becomes easy. This is what my typical theater setup involves. The surgeon is in line with the hip to be operated. The assistant lies on the left side, and the scrub nurse with the Mayo stand on the right. The TV monitor is placed right across on the contralateral hip area, and the space between the two legs accommodates the image intensifier, because fluoroscopy plays a very important role throughout this arthroscopic procedure. Now, it's very important to obtain joint distraction under fluoroscopy guidance to prevent any iatrogenic complications. And once the patient is initially positioned on the fracture table, prior to prepping and draping, one needs to ensure the amount of distraction. And this distraction is typically around 100 to 400 newtons, or around 22.5 kilograms. And this distraction ensures a safe portal placement, as you can see here in the bottom image intensifier photograph. Also, it is important that at least the first portal is placed under fluoroscopy guidance, and then subsequently additional portals can be placed through the arthroscope via the triangulation technique, which all of us are very well versed with. When it comes to portal placements, there are a number of portals described to address varying types of evolving pathology and indications, but the commonly used portals, in the interest of time, are the anterolateral portal, the posterolateral portal, the anterior portal, the mid-anterior portal, and the Dalla portal for the central compartment. And for the peripheral compartment, they are typically the anterior and anterolateral. However, a high anterior and a low anterior portals are also described for addressing the peripheral compartment. So typically, like the shoulder surgery, surface landmark is very important. So it is important to identify the anterior superior iliac spine and the greater trochanter. And irrespective of the size of the soft tissue envelope, these two prominences are reasonably well felt. But if in doubt, then if you take the finger down the ASIS and distally, one would come to the tip of the trochanter. Thereafter, the first line is drawn along the long axis of the anterior superior iliac spine, and the second is drawn perpendicular to it, passing through the tip of the greater trochanter. And this forms the landmarks for portal placements to minimize any iatrogenic neurovascular injury. So I'll just talk you through a few landmarks of these common portal placements. So the anterolateral portal typically lies 2 centimeters anterior to the tip of the greater trochanter. As you can appreciate, because it is anterior, it has to be directed superior and posterior to reach into the hip joint or the central compartment. And that is what typically an anterolateral portal placement would look like. The superior gluteal nerve is at risk when making this portal, and typically the general rule is that when you make these portals, you just make an incision or a stab incision up to the subcutaneous tissue and do not penetrate your knife into any further deeper planes. The anterolateral portal is useful to visualize the anterior labrum, the anterior part of the acetabulum, and the femoral head, as seen in these nicely illustrated pictures. The second portal is the posterolateral portal, and as the terminology suggests, it is placed 2 centimeters posterior along the line of the tip of the trochanter, and because it is posterior, it has to be directed anteriorly and cranially to reach into the central compartment. And that is what a typical placement for the posterolateral portal would look like on surface marking. And the sciatic nerve is at risk while doing the procedure, and therefore in the supine or the lateral position, any kind of over-advertent hip flexion is to be avoided, because that would bring the sciatic nerve very close to the trajectory for this portal placement. The posterolateral viewing portal offers a good visualization of the posterior part of the acetabulum and the labrum, and also the corresponding part of the femoral head. The ligamentum teres can also be seen through this portal, but it can also be seen through the anterolateral portal. Now, the anterior portal is typically placed at the intersection of the two lines which I just described, and it lies around 4 to 6 centimeters distal to the anterior superior iliac spine. And because it is distal, with common sense, it has to be directed cranially and medially to reach into the central compartment. And that is where it would typically lie on surface landmarks. The lateral femoral cutaneous nerve is at risk, and once again, it's important to only make a stab incision up to the subcutaneous part and then thereby go into making a deeper trajectory. This portal is useful to see the end-on view of the acetabulum and the cortiloid fossa and the lunate fossa of the acetabulum, and also the articulating part of the femoral head. The other commonly used portals are the mid-anterior portal, which is typically 5 centimeters distal to this anterior portal and a touch posterior, and also the Dalla portal. And these portals are useful doing therapeutic procedures like labrum or FAI surgery, because the trajectory is more or less straight, and it prevents any damage to the intraarticular tissues like the labrum or the articular cartilage. Moving on to the peripheral compartment. So one important aspect to remember is that after the initial fluoroscopy to determine the distension of the joint, the traction is released and the extremity is prepped and draped. And when we commence the surgical procedure, the traction is reapplied. This is to minimize the traction time and thereby minimize the complication of nerve injury because of secondary traction. So the second part of the hip arthroscopy involves access to the peripheral compartment. For this, the traction is released, and typically the hip is and the knee are flexed to 45 degrees. And this really relaxes the anterior capsule and the iliofemoral ligament, thereby allowing easy access into the joint. And either one can use the same anterior and the anterolateral portal, but it's just that this time they are directed more towards the head-neck junction and inferiorly to reach to this peripheral compartment. So these are the typical portals, or one may resort to use a high anterior and a low anterior portal depending on one's comfort. And the peripheral compartment is typically used to perform FAI type of surgery for the psoas tendon type of procedures. And this is what it would allow access to, as mentioned earlier. So while gaining access into the hip joint, it is important to apply the desired traction under fluoroscopic guidance. That creates a negative pressure gradient, and the insertion of a 18-gauge spinal needle into the right plane under fluoroscopic guidance, both on AP and lateral images, would ensure that once the hip capsule is breached, one can hear a pop sound, and either an air distension or a saline distension can be performed to further dilate the capsule to minimize any further iatrogenic injury during the definitive portal placement. So after the spinal needle is introduced, the guide wire is passed through it, and then the spinal needle withdrawn as seen here. And on top of that, a dilator with the help of a dedicated handle is inserted in a twisting manner. And once again, a pop sound confirms the proper entry into the hip joint at the central compartment. And in the initial stages, I would recommend that this is done under fluoroscopic guidance to make sure that we get the correct access. Like any other joint, be it knee or shoulder, it is very important to have a systematic evaluation of both the central and the peripheral compartment. And each surgeon with time has its own way to adapt and has a desired stepwise process. So there is no didactic right or wrong method, but having a systematic approach would minimize omission and also any potential errors. So in summaries, the hip arthroscopy in the last decade has evolved rapidly with significant advances both in the understanding, imaging, and instrumentation. It is, however, important to remember that it is a technically demanding procedure that does require a significant amount of training and experience. And in the experienced hands with appropriate and safe patient positioning, portal placement, and with the right indications and potential interventions, one can achieve a very good outcome. Thank you very much.
Thank you, Shreyash.
Thank you very much, Shreyash. Till the time we go to the next question, there is a question which has come up, Shreyash. Do you start with a 70-degree scope, or you start with 30 and then shift to 70?
I do hip arthroscopies only with 70 degrees.
Only with 70, perfect. Okay, yeah.
You can start sharing the screen.
Can I now request Dr. Munting to please share his two presentations, the first one on FAI and the second one on cartilage repair and role in degenerative joint disease.
You have to unmute yourself.
Now, there, can you hear me?
Yes, yes.
Okay, thanks, Shreyash and team. Thanks very much for the invite. It's an honor. And I hope you enjoy my talks. This is a synthesis of my experience of now 12 years or so doing this kind of surgery, and comes on the background of primarily initially open work. But I do feel that hip arthroscopy has made a very important contribution to our understanding of the hip joint as a whole. So to get on with the chat, femoral acetabular impingement. There are two big problems with FAI. The first one is that surgeons have a problem that when they think that they can deal with all issues related to the hip through a scope. And I think the second one is what I see a lot, and perhaps you'll see a bit more of, is that physiotherapists don't realize that soft tissue presentations often hide underlying joint pathology.
Share your screen, please.
Let's just go down. Can you see my screen now? Sorry.
No, still not is there. Still not, it is not there.
Try again. Can you see that?
Yes, it is coming. Yeah, now it is there.
Okay, perfect. Apologies. I'll enlarge. Right, so I'll continue with the talk. The new title for FAI is essentially that of femoroacetabular impingement syndrome. This has been defined by consensus paper from the Warwick group headed by Damien Griffin. And this is a group of surgeons and physiotherapists and sports physicians. Some of these surgeons specifically only deal with groin issues. These colleagues of ours came together to formulate this paper, which is a free paper that you can pick up in the Journal of Sports Medicine in Britain. And they discuss what the definition of FAI syndrome is, how it should be diagnosed, what the appropriate treatment of the syndrome should be, what the prognosis of it is, how someone should approach a patient with an asymptomatic FAI type hip, and what outcome measures should be used to assess their treatment, and what the future research perhaps should be that we should conduct. So as we know, FAI syndrome and these two animations, I'm sure many of you have seen already, is really an abnormal symptomatic contact between the proximal femur and acetabulum. And I would implore you to keep that sentence in mind. So on the left, we have the pincer type impingement, which is predominantly a labral damage process, versus CAM, which is predominantly a chondrolabral separation, ultimately chondral damage process. So the diagnosis, according to the paper, is made if you have the correct symptoms, the correct clinical signs, and radiological findings. If all of these are present, then you will be able to make the diagnosis of femoroacetabular impingement syndrome. Typical symptoms are obviously those associated with pain that come from the hip, typically from the groin, with radiation toward the knee, anteriorly in the thigh or medially. Sometimes these can radiate around posteriorly towards the deep gluteal area, and has been described by Dr. Bird as the C sign, as the patients often hold their hip in that manner. The clinical signs are often sometimes subtle and can be just a little bit of diminished external rotation range as far as passive movement is concerned. But certainly the typical impingement tests, the Faber test, or with anterior hip pain, these are typical clinical signs. Radiological features are based on a plain standardized X-ray, and I would implore all of you who get into the surgery to make sure that you have a good relationship with your radiology units, to standardize your X-rays so you can make appropriate diagnoses. Obviously, these X-ray findings would indicate evidence of pincer or CAM type morphology. One can enhance this, of course, by doing injections with intraarticular local anesthetic, with or without steroids, and then use other ancillary methods like CT scans or MRIs. So once we have a diagnosis, our treatment options are essentially, of course, conservative care, which is essentially a change in activity level of your patient. The physiotherapists often see patients first and try and manage them with physiotherapy-led treatment. And then, of course, we as the surgeons come in, and this leads to arthroscopic and or open intervention. But I would say that the surgeons and the physio certainly have to work together to deal with this problem. Treatment considerations. If asymptomatic FAI morphology is noted on an X-ray, surgery is rarely indicated as per the consensus agreement. Treat the source of the pain. So for example, many patients would present with adductor strain or tears. There is often an association with CAM morphology in these cases. The treatment here is physiotherapy until such point as you can demonstrate the pain is directly coming from the hip. Individualize your treatment, especially when it comes to sport. So if you look at the pictures on the right, these athletes have high flexion moments as far as hurdling is concerned. But the athlete on the right would be a patient that you would want to have them externally rotate their foot to disengage a CAM lesion versus the one on the left. If he should have a CAM lesion, this is not the way he should do hurdles. It's just an example. Activity modification is, of course, the vital part of conservative treatment. Now, natural hip movement. What is natural hip movement? And this is now the home movie time, and I'm going to play this video I made for some of my physios. Please enjoy it.
Movements around the hip and how the hip is actually designed to move on an evolutionary level. So, because of the neck orientation to the femur, if you try and do side splits with the knee facing forwards, it's basically impossible, as you can see, without the ball hinging out the socket. How the ballerina trainers get around this is they rotate into external rotation and then flex their perineum all the way down to the floor. This allows that movement. Femoral acetabular impingement is very similar because the axis of the neck is at about 45 degrees and perpendicular to the socket. Direct forward deflection is not a good hip movement, particularly with internal rotation. Tend to impinge in all cases. The same can be held for flexing forwards. You flex into a joint every time you get the same effect. Hips are designed to essentially be unladylike. You open the hip ABD duct, slightly externally rotate, and then flex deeply. The range of motion is phenomenal. Think about all those huge sumo wrestlers. When they do their deep squats, they externally rotate and they flex all the way down to the ground. They do not get hip problems because they've adapted their movements appropriate to the bony physiology of them.
Right, so after that small video, treatment, surgical treatment. The aim is to improve the morphology as well as repair the damage associated with bony morphology of the hip. So when it comes to our options, we have open surgery. This can be through a limited mini anterior approach or an open hip dislocation procedure, as with the trochanteric flip osteotomy described by Gantz many years back. And I would encourage you to read this seminal paper. Then, of course, there is the periacetabular osteotomy, which is a powerful mechanism of changing the morphology of the hip accordingly, especially with the global retroversion cases or dysplasia cases. Proximal femoral osteotomies are also sometimes required in order to address the other side of the coin. And then we have our hip arthroscopy. And this picture taken from Thomas Bird's book is one of the pictures I'm sure you've seen a lot of. The prerequisites for FAI surgery is, of course, the diagnosis, the failure of conservative treatment, a close working relationship with your physiotherapist, particularly for post-op rehabilitation, detailed and an intimate knowledge of hip anatomy. Be informed with respect to current concepts related to the pathomechanics of the hip. And I'd ask you all to read this very good paper by Moritz Tannis and his group from Bern. And they looked at 538 hips treated with FAI surgery. In their unit, they do a lot of open surgery. And they looked at the orientation of the acetabulum and the femoral neck and their relationships. And they found that only 32% fitted within what they considered normal, i.e. up to 70% of hip morphology is abnormal when it comes to FAI surgery. Be educated in the diagnosis and the indications for surgery, and obviously skill yourselves up in terms of the surgical techniques. The consensus on outcomes are that physio does work with symptom improvement of up to 2 years, a fairly short time. At the time of the consensus paper, scope surgery showed significant improvement for up to 5 years, and open surgery, which has been around longer, shows definite symptom improvement as it relates to FAI surgery for up to 10 years. There is a demonstrable association between CAM FAI and osteoarthritis. There is no evidence yet that pincer FAI is associated with osteoarthritis, but we feel it is likely. And there is no evidence yet that surgery for FAI syndrome alters the long-term risk of subsequent osteoarthritis. Hopefully this will change. Hip surgeons have been very active, probably driven, I think, a lot by the funders, but essentially we have in our back pocket now a number of very good level 1 studies which demonstrate the difference, the benefit of surgery over conservative treatment, i.e. physiotherapists. And I refer you to the FASHION trial run by Damien Griffin and the FATE study, which both demonstrated this phenomenon. There are a number of studies in the making, which we are looking forward to the results of. The one by Femi Ayeni from Canada was due to be presented at the ISHA meeting in Ottawa. This obviously won't happen this year, but I have it on good authority that this is very positive. And then there are a few other studies related to sham surgery, which the bases for have been published. And these results will come out in the near future, the party trial and the HARP trial. So essentially, we have level 1 evidence that our FAI surgery works and is better than conservative treatment in the form of physiotherapy preoperatively. The decision-making with respect to operative procedures for FAI. The take-home message from my point of view is that FAI of the joint is primarily a bone problem. So this is where arthroscopists can run into a little bit of trouble. It is not like a shoulder or a knee. The hip involves a lot more of the bone than it does for the other joints mentioned. Often, obviously, the soft tissue issues are secondary. This is a good approach written up by Brian Kelly from the Mayo Group, and I use this in how I address my hips. And this is the layered approach to your hips, looking at layer 1 being the bone and cartilage, layer 2 being the fixed structures such as the labrum, the ligamentum teres and capsular structures, and the synovium. You have the dynamic movement layers, followed by the neurokinetic layers. The relevance of this is that if you look at perhaps layer 1 being the static bony structures, you can have a static overload scenario such as developmental dysplasia. You can have a dynamic overload or impingement problem when you come to FAI, and you can have dynamic instability as it relates to supraphysiological movement of hip, all of which leads to injury with respect to layer 2, namely the musculoskeletal layer, the muscle layer, and this will then lead to the static ligamentous layers, namely the labrum and the ligaments, etc. These will then result in problems with respect to this layer, and again, further dynamic instability of your hip, which then, in the next slide, you'll see involves layer 3, and this is your contractile layer. The athletic groin pain we may come across as per the Doha agreement written up some time back. This layer is important for dynamic stability around the hip, pelvis, and trunk. And if you already have instability because of layers 1 and 2, you often get compensatory injuries in the form of enthesopathies and tendinopathies. So surgery for FAI, an approach based primarily on my experience and obviously what I've been taught through the years by my colleagues. Categorize preoperatively your FAI type. It is mostly either CAM or pincer, and occasionally you might find a mixed picture. I'll give you an example later. Confirm the mechanism. I use a dynamic arthrographic study, which you'll see soon. That manage the damage, obviously, that you expect and will find, and remove the bone impingement areas that are causing the problem. Remember, the indication for surgery is pain. CAM is evidence of early chondral injuries, so operate. Pincer is primarily damage to the labrum, and conservative first, then surgery. And physiotherapy we know is inferior to surgery, so don't wait, but rather involve them after surgery. So this slide is probably the most important of the talk. The surgical decisions are damage dependent, but overall for arthroscopy of a fairly routine nature. Bone morphology may sometimes demand open procedures. So in the case of pincer FAI, one usually does an acetabuloplasty or rim resection. You then do labral repair with or without a takedown procedure. Mostly people are doing an undermining of the labrum at the rim at this point. Occasionally one requires a labral reconstruction if the labrum is irreparable. Occasionally there is a requirement for neck osteoplasty as for CAM surgery. This is if you have a reactive periosteal bump. Sometimes open surgery and hip dislocation procedures are required, particularly if you have severe profunda, typically a CE angle of greater than 40, or you may require, in fact, a periacetabulum osteotomy or proximal femoral osteotomy based on the relative versions of the acetabulum and the femoral neck. With respect to CAM surgery, we're primarily doing neck osteoplasty work to remove the CAM lesion. Often, there is acetabular work as well if you have a deep enough socket, where you can undermine the labrum, repair it back to a new base, and remove the damaged rim of cartilage. Cartilage damage is primarily what you will be doing. Damage management is what you'll be doing with CAM surgery. And this can take the form of chondroplasty mechanically or with radiofrequency probes, microfracture with or without abrasion, with or without flap preservation. I'll discuss this in my next talk. Microfracture or abrasion can be used together with chondral graft procedures and or fibrin glue, typical AMIC or Mackie type procedures. An alternative would be open hip dislocation. These are sometimes required when one has extreme lateral cams, which may place the vascular structures at risk with scope surgery, and or you have femoral head condyle damage areas. This is rare, but I feel requires open procedures. So intraoperatively, in the case of pincer impingement, I use a dynamic arthrographic study just before I operate on table. And you can see the pelvis moves without the head subluxing as soon as the neck hits the rim. There's always a typical intraarticular picture here with the labral damage to a varying degree and subluxation off the rim of the acetabulum. The treatment for this is to do a rim resection and repair of the labrum in its new position. I, for the most part, use extraarticular based sutures and try not to encircle the labrum with my permanent sutures. Cam impingement is different. So you'll see from this arthrogram that the head separates from the acetabulum prior to the whole pelvis moving. And this normally always indicates an area where there is a cam abutment to force the head out of the socket. Fluoroscopy is essential in FAI surgery, in my view. The typical intraarticular finding is always a flap of cartilage separating from the labrum. Often the labrum is in fact intact and attached to the rim. This is an outside-in injury pattern. One can, as mentioned before, do a rim trim and repair the labrum back down, and then just resect, as you see here, the damaged cartilage and use a radio frequency probe to smooth this down. Do not forget about the cam lesion and resect this appropriately. Using fluoroscopy to guide you, as well as direct visualization in terms of the extent of bony resection. Sorry. So sometimes one can get mixed messages. So in this patient, there is a deep socket, but there is obvious also cam morphology. What, however, is causing the pain? In his case, there was demonstrable labral injury anteriorly towards the psoas groove, but also superiorly and laterally, there was evidence of chondral damage with some delamination. So this patient required, of course, the usual, which is rim resection, repair, and then subsequent resection of the cam lesion. Occasionally, these orthographic studies can change my plans. Here we have a patient who has a deep socket, a centi-edge angle of about 39 with expected pincer impingement. But the orthogram shows me that there is intact separation. So I'm looking for an area of cam impingement. The intraarticular finding is predominantly that not of labral damage, but rather chondrolabral separation and early delamination. So the mechanism here is primarily cam impingement, contrary to what you see on the plain X-ray. And one can see on the periphery or equatorial of the side of the head, the cam lesion, which required appropriate resection. Now, a controversial area is dysplasia and surgery and hip arthroscopy, but occasionally you find that, that dysplasia is associated with other problems. So with clinical graphic studies, we are able to see that there is indeed undercoverage as far as the head is concerned, but also that there is excessive anteversion of the femoral neck. The intraoperative findings are interesting, though, that there is not an enlarged labrum, which one would normally find with a dysplastic type picture. And the picture is more that of delamination again, i.e. cam injury to the chondrolabral or chondrolabral junction. And the clinical graphic study helped us with this in indicating certain area of alpha angle increase, together with, of course, the orthographic study I showed you before. So the treatment would be cam resection, but in this patient's case, I included a derotational femoral osteotomy to address the anteversion. So in conclusion, recognize FAI syndrome, X-ray patients early, don't wait. Understand the effect of sport or movement relative to the constraints of hip morphology. The hip is primarily, as I said, a bony issue. Understand the interplay between the anatomical layers and their functions. And understand that pincer and cam have recognizable intraarticular damage patterns. Understand that cam FAI leads to early cartilage damage. And if there is pain, then surgery sooner, followed by appropriate readjustment of the function of the anatomical layers with the help of your physiotherapists. This is a team approach. Thank you very much. That's the end of the first talk. If you are happy, I will continue with my next talk, which is to do with cartilage injury.
Please go ahead, Dr. Munting.
Thank you very much. So, chondral surface damage and hip arthroscopy. A little bit of a recap. And I think this is important because as we get older, we forget about these details. But the articular cartilage is made up of discrete layers, as you know, and it is intimate in terms of its attachment and interface with the underlying bone. There is an extracellular matrix of a particular design, and this attachment stems from the bone all the way through to the superficial surfaces. And the extracellular matrix is, of course, predominantly consisting of the proteoglycan molecule based on a string of hyaluronic acid with attachment of glycosaminoglycan chains. The structure as a whole is minimally, has minimal chondrocyte content. The extracellular matrix is mostly type 2 collagen, and the proteoglycans and the glycosaminoglycans form a large proportion of this, but most of it is water. Chondrocytes are fussy and few and far between. Their volume is very small. And it explains why cartilage does not naturally regenerate by cell turnover, but rather by renewal of its extracellular matrix. Chondrocytes obtain information exclusively indirectly through mechanical forces predominantly and associated tissue mediators, which then would hopefully stimulate them to produce extracellular matrix. So one can conclude based on this that both prevention of and management of cartilage lesions demands a normalization of the mechanical forces across the joint. So management of chondral lesions and hip arthroscopy. Obviously treat the lesion, but manage the cause. It is important to always classify. We're all familiar with the Outerbridge classification, but I do prefer the Beck classification from 0 to 5, which is more in keeping with what we find in arthroscopic hip surgery. Generally, as far as arthroscopy is concerned, any lesion greater than 2 centimeters has a worse outcome. And the position of the lesion is irrelevant because hip arthroscopy and chondral management is more amenable to acetabular side damage rather than femoral head damage. The latter, I feel, requires open procedures because you need to stitch in your grafts. Manage the cause. Adjust for whatever sporting activities the patient does that may result in the injury, and deal with the bony morphology and or pathology. And typically this is the FAI issue, the dysplasia patients, and the other deformities we come across. And in some areas, a large number of patients have AVN, and others, don't forget about rheumatological disease. So unique considerations in hips with respect to chondral management is that access is not easy, and we've seen this in our previous talks. The acetabulum by its nature is a contained surface, which can make it difficult to get at, particularly with a high center edge angle or a large amount of retroversion. It is concave. So, for example, doing mosaic plasty is difficult because you won't find a donor surface that has a concave chondral surface to match. There are varying zones of thickness as far as cartilage surfaces are concerned. So in the weight-bearing surface, it can go up to as much as 4 millimeters, and in the rest, quite low. Deep sockets have globally less cartilage. Dysplastic sockets have thicker cartilage. Chondral damage pattern will vary depending on the pathomechanics of the hip. And one has to be cognizant, as mentioned before, of the version dynamic associated with the hip joint, whether or not there's an element of subtle dysplasia anteriorly or directly laterally, and the presence of camming. The femoral head is uncontained in essence, specifically with particular movement ranges, and it is also convex. So that means that if you put on a chondral graft, it's not going to stay there without suturing in, hence my opinion that this needs to be done open. Chondral thickness, however, is uniform, but apical lesions are more difficult to get at versus equatorial zones. Congruence is important, and we know this already in the case of Perthes and subsequent OA and CAM lesions, which result in cardinal damage. Further considerations would be that we need to aim to normalize or optimize the mechanical forces through the cartilage surface, as mentioned before in my lead-up in my introduction. The repair of labral function, because this normalizes fluid flow between the cartilage surfaces and will thereby stimulate appropriately the osteocytes. Also, the labral function spreads load with less point loading and therefore protects cartilage. Manage, of course, the cause, whether it be sport or bony morphology issues. Optimize the surface area of contact. So if you have dysplasia, you need to do PAOs. If you have version issues, these need to be addressed. Remove incongruence. These are the cases such as Perthes and CAM lesions. For the hip, management of soft tissue damage almost always requires some form of bony surgery. Hip arthroscopy has limitations with respect to changing bony morphology. So in essence, and for practical purposes, the main cause of cartilage damage and the indication for hip arthroscopy is CAM FAI syndrome. Why do I say this? It's basically because chondral damage is mostly on the acetabular side, which is amenable to scope work. The acetabulum is accessible and contained, so you can put in a graft without suturing it in. The CAM lesion is also peripheral on the femoral head and easily accessible. And CAM FAI syndrome is a proven cause of OA, particularly in our younger group of patients where we want to treat them with arthroscopic means. So if you use Beck's classification and you use the grading system, you would manage the first 3 grades with a chondroplasty of some sort, either mechanical or using an RF. If you have fissures, one can do microfracture within. These are small lesions and amenable to this management. If you have debonding or separation or delamination with an intact cartilage layer, one can consider doing microfracture underneath this and or injecting fibrin glue. So Ricky Villa wrote a very nice paper in this regard, and he uses fibrin glue to stick down these flaps, because once the head goes back in the socket, it will push the cartilage layer back down. When one has cleavage defects or actual loss of cartilage, one has to do debridement, and this needs to be followed with either abrasion or microfracture. Microfracture alone if it's a small lesion perhaps, and otherwise one has to use some form of collagen matrix grafting procedure. This can be a single sitting, as in the AMIC or the AMECT procedure, which I'll discuss shortly, or one can use Mackie type procedures that you'll be familiar with in respect of knee surgery. The femoral head is a different animal, and the only thing you can really do with any form of success arthroscopically is the microfracture and stabilization of flaps. So here's an example of typical CAM surgery, and you've seen a picture in my previous talk. If there's enough socket depth, i.e. less than 4 millimeters, enough socket depth, then I often measure my socket depth directly using my instruments. You need a minimum of, in the anterior wall, of about 15 millimeters, which equates to 25 degrees CE angle or anterior CE angle in an average size 50 millimeter diameter hip. You cannot resect more than 4 millimeters without consequence. So if your chondral layer of damage is less than 4 millimeters, you can consider a rim resection and undermining this layer of damaged cartilage, repairing your labrum, and resecting the damaged cartilage. Don't obviously forget about the CAM lesion, which needs appropriate resection. Try and aim for a concave, for a convex surface and not a concave apple core type effect. This maintains your suction seal of the labrum. If chondral delamination is noted with poor flap cartilage, then one needs to debride this to a stable base. And you can use a shaver and or ring curette, which I find the most useful. Eventually you have your debridement, you do microfracture or abrasion, and then place a graft on top of this. And I use a particular collagen type graft, which you'll see in the next slide. So here's another example of the AMIC procedure with the damaged and irreparable and unsalvageable cartilage delamination. We do the resection to a stable base. We do microfracture or abrasion, as I did in this case with the shaver, ensuring once you remove the pump pressure that there is adequate bleeding. One then templates appropriately the size and sucks all the fluid out, so no more pump. Once this is done, you can place your graft. And in this patient, I used the Foley's catheter bulb to pressurize the graft for a few minutes onto its surface. And then we're left with a nice cover of the lesion. And here's an example, which I believe is available in India. It's from Biotech, and it's an equine collagen with a slightly rougher surface on the one side and a smooth surface on the opposite side, which is very amenable to this kind of surgery. So a good reading reference would be papers by Andrea Fontana, who described the AMIC procedure. He has 5-year follow-up and a further 8-year follow-up in terms of the literature. And he describes his technique in the Arthroscopy Techniques Journal, and there's your reference. In addition, there's a very recent paper by Michael Lunick and co, where they looked very carefully at chondral flaps and their viability, and showed that there was a 70% of the chondrocytes were still present, i.e. a 30% loss, that there was an ability of these chondrocytes to migrate within fibrin glue surrounding these flaps, but their ability to create a decent extracellular matrix was fairly poor, and this paper questions the usefulness of keeping chondral flaps unless you can demonstrate that they are very good quality. There are newer chondral graft options. One can harvest and do a 2-stage procedure, producing chondrospheres or again collagen matrices, and then placing these in the lesions. Or more recently, there's been a nice approach where you can take chondral or chondrocytes and harvest them from the CAM lesion itself, combine this with a so-called biocartilage, which is essentially a medium of chondral extracellular matrix and growth factors produced by one of the companies, combine this with peripheral blood, and then inject them in and stabilize it with fibrin glue. This is, of course, a single-stage procedure, and the validity of it has been presented in this paper written by Hans Gollwitzer and co, where they demonstrated that the chondrocyte viability from the donor site, the CAM lesion donor site, is good. Now, to end, just a word on hip arthroscopy and osteoarthritis. As in knee arthroscopy, I think we have shown that really for pain and the presence of OA, arthroscopy is not that good. Access is always a lot more difficult due to a tight contracted capsule with or without numerous osteophytes. And this leads often to a much higher risk of added iatrogenic chondral damage. Any head chondral damage or central subchondral cysts or joint space less than 2 millimeters, and if there is associated dysplasia or raised BMI, are all universally poor prognosticators and contraindications for hip arthroscopy in the face of osteoarthritis. Microfracture and debridement have very poor outcomes, especially if there is excessive chondral loss and an age above 45. The modern hip replacement is an effective pain-relieving procedure, and reliable longer-term outcomes have been demonstrated, particularly anywhere over the age of 52. So I think this is your best option. And I refer you to a very good review on this subject just last year by PM IST and his Canadian group, where they give you a good review as to what works and what doesn't in the population group as far as hip arthroscopy is concerned. Thank you once again.
Thank you very much, Dr. Munting. Both your talks were very informative and elaborate. You mentioned the importance of FAI diagnosis and also your approach, especially in the intraoperative setup, as to how you choose the right patient so you get the correct outcome. And also in your second talk on cartilage defects, you highlighted a few options. In India, we have 1 or 2 out of those. And also importantly, you just shared 1 or 2 slides on its role in degenerative joint disease, which really sums up that really there is not much of a benefit of hip arthroscopy for this degenerative joint disease type of procedure. Thank you very much once again. And I would like Dr. Prasad Gourineni to kindly share his talks. He'll be talking first on labral repair and reconstruction, and secondly on the role of hip arthroscopy in the pediatric patient. Thank you.
Thank you, Shreyas. All right, my first talk is vestibular labral repair. I saw Thane mention a little bit, show some examples already, which is a good introduction. Vestibular labrum. You all know where the labrum is by now. Labrum is the outer lining of the acetabulum all around. There's the capsule. There's a recess between the labrum and the capsule. Vestibular labrum is a fibrocartilaginous ring around the acetabular rim. It extends the joint surface and increases head coverage. But that may not be the main function. The main function is it forms a nice suction seal for stability and joint loading. The labrum, though it looks like it has blood supply only on the outer aspect, even after repair, any repair, the labrum heals really well. And tears are often secondary to bony abnormalities. Thane mentioned a little bit of this before. Labral tear is not a diagnosis. Labral tear is usually secondary to impingement or dysplasia. You need to diagnose those, correct those first, and then decide if a tear requires a repair or not. And repair in multiple studies, both open and arthroscopic, is shown to be better than excising the labrum altogether. But a minimal debridement of the labrum is totally fine, where it's not too unstable. This old classification of labral tears, Seldes type 1 and 2, still is quite relevant for me. Type 1 is almost like chondrolabral separation when a cam impingement. And type 2 are the tensor impingement type of intrasubstance tears. There is traumatic avulsions, radial tears, flaps, and degenerative tears that can be debrided, but the type 1 and 2 are usually repaired. Again, causes. FAI is the most common cause of labral tears. I think anywhere, and in my practice, that's a predominant reason I do a labral repair. Dysplasia, the labral tear is there almost always in symptomatic dysplasia. I don't have to repair the labral tear if I do a PAO. I do it only when they have mechanical symptoms attributable to an unstable labrum prior to my operation. And trauma causes, hip dislocations cause labral tears that are often unstable, and it's nice to repair them if you're there. So indicated for labral repair. Pain from an unstable labrum and adequate tissue in a younger person. I don't do labral repairs in an older person. They won't even operate on older people for labral tear in general. So it doesn't apply. You shouldn't have too much arthritis. There's no point in doing a labral repair if somebody has arthritis. Any type of surgery is useless and they have arthritis already. And then if the uncorrectable deformities, you may do a good labral repair, but the deformity is not taken care of, cannot be taken care of, the labral tear will happen again. So you need to correct the deformity before you do a labral repair. And then identify and treat that deformity at the same time as you repair the labrum. And most labral tears are repairable in my hands. Typical example of a cam lesion. I already repaired the labrum here, but this is a cam lesion. If you don't take care of the cam deformity, whenever they flex up, this labral repair will be broken and the tear will recur. So this is how you find a fluoroscopy and dynamic exam, take the cam out, and finish off with a nice osteoplasty. And this will protect your labral repair. So the technique, like anywhere else, you want a fresh bone bed. So even unless there's dysplasia, try to trim 1 millimeter of the rim to have fresh bleeding bone. And I pass sutures around the labrum, but you can pass it through the labrum also if you're comfortable. And then place the anchor. What's important is when you drill your anchor, look at the articular surface to see if there's any bulging from the drill bit before you even try to put the anchor in. That way you'll avoid placing an anchor close to subchondral bone, cartilage. Then you oppose the labrum to the acetabular rim with suture. You can tie knots or you can do knotless anchors. And if you're doing knots, like Thane showed, you want to put the knots away from the femoral head. So you put the knots on the acetabular rim side of the repair. So this is a bad thing. This should not have happened. If somebody watched where the drill bit went, they won't even try to put this anchor in. Now taking this anchor out destroys a lot more acetabulum. So avoid putting this by looking at your drill, put the drill in and then look at the cartilage, make sure that the drill is not anywhere close to the cartilage and then put your anchor in. Like I said, you can do sutures around the labrum if the labrum is small, but if it's big enough labrum, you can do a base fixation by passing through the labrum. There's no big difference. Outcome studies have shown no difference in the two techniques. Augmentation is something I usually do. Whenever I do my rim resection, there is some tissue that's still attached to the labrum. So I usually wrap this tissue around to bulk up the labrum if it's small or the tissue is poor, and I repair this all together, put it back against the acetabular rim. This is an example where this is a labral tissue that's folded down. This is articular cartilage that got exposed after rim trimming. So I chose to take this articular cartilage and wrap it with the labrum to the acetabular rim. So I'm biting very close to the rim, leaving all this articular cartilage, augmenting my labrum. Labral reconstruction. I don't do a whole lot. My patients are really young and usually I can repair them. But if it's a poor tissue or I have to damage the labrum during my operation, then I do a labral reconstruction. The options are to use allograft or autograft. I usually use an allograft, a hamstring tendon that's available in the freezer. We bring it out, thaw it, and put it on. Symmetric allograft is very useful for this. This is not my own slide, but it's a beautiful slide by one of my friends. It's a labral reconstruction. He's very aggressive with labral reconstruction. So use an IT band allograft, and it doesn't look like an IT band, wrapped up nicely, tightly, sutured together, and then puts multiple anchors to recreate the labral seal. So I'm showing you one case. It's a 19-year-old with acetabular overcoverage, plastic impingement with -5 degrees of mental rotation, so very stiff, plus 20 is healthy, so it's 25 degrees lacking. So I chose to do, that's his X-ray, that's his posterior wall, little overcovered. The anterior wall is much more overcovering, and have plenty of bone to remove to improve his range of motion and relieve his impingement. So this is what I did. That's the lateral view. Arthroscopy showed some frayed labrum. You should have pincer impingement, but I don't see classic pincer damage. But all this can be debrided nicely with still having enough labrum to repair. This is my arthroscopy. So I removed about 8 to 9 millimeters of rim, acetabular rim. This is where the old rim was, and this is how far I took it. So all the cartilage underneath will get exposed, like here. The bone is removed and the underlying cartilage. This is the labral tissue folded down. So here, the cartilage is too excessive to wrap it up. So I'm going to show you in a video, hopefully it will play. I'm excising the extra cartilage. So the knife is separating the labrum from the articular cartilage. And I'm removing the unsupported articular cartilage because the bone is not supporting this cartilage anymore. We're excising that cartilage, typically from the anterior rim, from about 12 to 3 o'clock position in right hip. Remove all the debris. All this falls into the acetabulum. It's not healthy to reduce back the head with the debris in the socket. Yeah, this is the stage when you're drilling the hole, look underneath at the articular cartilage to make sure that the drill is not anywhere close. And like I said, I pass sutures around the labrum and not through the labrum in general. I'm going inside to grab that suture. So it's a luggage tag type of suture around the labral tissue. I'm not happy with where it is because my hole is much more distal. As you can see, the hole is on top here. So I'm going to move the suture closer to the hole so that I'll get better reapproximation of the labral tissue. Not a very fast surgeon, so I take my time to get things right. There's a knotless anchor. You can see how it pulls up the labrum. And this particular anchor allows me to adjust the tension on the labrum, on the sutures, even after, right now I'm adjusting the tension. Happy with it, then I cinch it. Cut the excess suture. And then you know that I need to place 2 more anchors at least. I typically use 2 to 3 anchors. Sometimes I have to go to a 4th one, depending on how big this section is. The same thing repeated again. Look at all the debris in the hip joint, drilling and the same thing being repeated. The next thing with the knotless anchors is the luggage tag suture. My anchor can be much far away from the rim and still I get seal on it. That would have to be placed. So that's how I do a labral repair. Do you want me to proceed?
Yeah, please continue with your next talk. Thank you.
Right. So hip arthroscopy in children. Like I mentioned earlier, most of my patients are really young, teenagers, a few young adults, but my predominant population is anywhere from 7 to about 18 is my patient population. So hip arthroscopy in general is uncommon, and then in pediatrics, it's even much more uncommon. There are very few reports on pediatric hip arthroscopy. There are few indication reports, and then Philippine has a small series. So very few reports and very few defined indications. Hip arthroscopy in general is difficult to learn, and in children, they have a few smaller bones, so you need to be a little more careful. The smaller structures, open physis is a concern, but at the same time, I don't have any problems with open physis. So I do operate on patients with open physis, FAI surgery, whatever I do. The acetabulum is not fully ossified, so I'm not very aggressive with rim trimming in young children with open periodic cartilage because the walls are not well defined and the crossover sign is false. So I will not do aggressive rim trimming till the acetabulum is ossified. And these children are less compliant with instructions, so you do a good job and try to not rely on them being compliant. And even my case series, though I do a lot of hip arthroscopy in children, it's a very wide variety of indications. So for each indication, the numbers are not very high. That's my typical setup. It's a supine arthroscopy setup. Sure. So distraction, pretty standard. Place the table in Trendelenburg position for contraction. At the foot, I put a very big perineal post, an 8-inch perineal post to lateralize as well as protect the perineum. Distract, vent the capsule, and then try to minimize traction time. Try to finish off everything within the first hour of traction. Standard portals like Shreyash sword, nothing special, even in children. I like this technique a lot. I don't know if other people do it or not. I palpate the capsule under fluoroscopy and make sure they're mid-lateral so that when I'm away from the acetabulum rim, I'm pretty sure that I'm not in labor. This works well in my hands. I can go right hand. So indicated in arthroscopy in children. Sometimes I may do it for diagnostic purposes, but that's very rare. These days, we're pretty good with clinical examination and MRI, so diagnosis is not unknown in most cases. Debridement, it's a good indicator for debridement, synovectomy, loose bodies, septic arthritis. I'm going to show you an example. I do even in babies, septic arthritis with a hip scope. You may think that it's too much of a kill, but there is a lot of advantages of using the scope for draining a septic hip. Impingement is the most common reason I operate even in children. FAI, idiopathic FAI is the most common reason, but I do operate for impingement for Perthes, Skefi, Protrusio, and then IAS impingement, lesser trochanteric impingement are all amenable for endoscopic or arthroscopic techniques. And a few cases where I did IT band release in the peritrochanteric area. And my own complicated when they're HO form, I can go back with the scope to remove the HO. You may say that it's easier done open, but I don't know. I like the idea of going back with the scope and removing it. This is probably a 2 or 3 year old child, septic hip. Actually, there's a video I'm going to play. So check my needle track. It's a Dean's port. Right? You all know how to put a needle in the septic hip aspirate first. From the front of the neck, palpating the neck, confirm that I'm under fluoroscopy that is deep enough. Aspirating the neck, I got it first, so diagnosis is confirmed.
Great. Good.
Then the portal is a simple portal. The needle is already there. You pass the guide wire and then the cannula, and this is the view you can get. And the washout is much more thorough. And if you see a lot of synovitis, make a second portal to do a synovectomy. So what I notice is my washout is much more thorough with arthroscopy than when I do open. I do open pediatric orthopedics quite a bit, and this is a much better washout. Within a liter or two of irrigation, hip is very clear, and the same institutional hole, nothing extra. Works really well. This is the youngest person I've done 5-month-old with a standard hip arthroscope. So you don't need a special instrument because the hip joint is big enough even in a little child to do arthroscopy. And this is the child's hip inside that you can see very well. And that's the scar. The scar doesn't matter as much, but it's the ease of, not ease, but the thoroughness of the washout. This standard teenager with pincer impingement, you can see the labrum is crushed, there's pincer damage. Right. I believe pincer damage does cause arthritis, though there are no studies to prove it. So this is the cam, typical cam with open growth plate. This is before, this is after osteoplasty of the head neck junction. In the case with mixed impingement, pincer, remove the rim, labrum repair with sutures around the labrum, and cam osteoplasty. And the cam osteoplasty goes medial to the physis because the cam is an epiphyseal deformity. Unlike a SCFE, which is a neck deformity, idiopathic cam is an epiphyseal deformity. So you need to go medial to the growth plate. This is not a common indication for me, but I've tried it a few times. You can remove the obstacles of closed reduction in a DDH patient, in a 2-year-old. Arthroscopically can remove the ligamentum teres, the pulvinar fat, nicely decompressed, and then the head can be reduced. But you can't do a capsulorrhaphy unless you open it again. This is a Perthes child, 7-year-old, healed Perthes, and this little bump is bothering him. He doesn't have good rotation and is impinging and has pain. I didn't want to wait any longer because it's going to cause more damage. We got an MRI. There's a growth arrest across his physis. So this is before the bump. I use fluoroscopy quite a bit. Then I do dynamic evaluation and fluoroscopy to confirm that I'm taking enough bone and not making a mistake. This is a mild SCFE. SCFE is doing pinch. Most SCFEs impinge. This anterior rim will abrade against the cartilage. This is how it looks arthroscopically. The raw bone is rubbing against the labrum. So a lot of people say SCFE is a cam, but I don't believe it's really cam. It's cam morphology, but the damage is not cam intraarticularly. Intraarticularly, this bump crushes the labrum like a pincer and abrades the articular cartilage inside. It's nothing like the chondrolabral separation. It abrades the surface of the cartilage. So this is how it looks, a scraping of the cartilage from outside in, and the patient with damage of the articular cartilage. So it's a good idea. If you cannot do an osteoplastic, do it primarily before this damage happens or prevent further damage. So this patient had an osteoplasty along with screw placement. So put the screw first and then do an osteoplasty. This is not for prime time. This is another SCFE. An ideal patient here because the slip is not severe, but bad enough to require an osteotomy. I do done osteotomies often for a SCFE. This particular patient did not want a big scar, and they requested that I do something minimally invasive. So I chose to do a done osteotomy with a scope. I've done only 2 of these, so you can actually do the osteotomy all the way across with burr. It took me almost 2 hours to complete it. And then once you finish, you try to align the head and the neck. This fixation is not easy, but we got 2 screws across in a lag mode. And this patient did well with no AVN. But this is not prime time. It's not fully figured out all the problems. I still have some problems of how to put the screws in when it's distracted. Thank you very much.
Thank you, Dr. Prasad, for sharing your indications and technique for managing the labrum, and also the indications in your day-to-day practice in the pediatric population. So that moves us to the last talk on complications. And am I audible and is my slide up?
Yes.
Okay. So hip arthroscopy complications. I think no talk on a topic is complete without actually talking about complications, because if someone's not had complications, then it's very simple. They haven't operated enough. But what is important to recognize is that we have to learn from our mistakes and try not to repeat them. And with the growing acceptance and knowledge in hip preservation surgery or hip arthroscopy through meetings and webinars like this one, there is an increased urge and desire to perform these procedures, and hence there is a potential risk of complications. Because these type of procedures are technically demanding, they have a steep surgical learning curve that may lead to a wide variety of individual surgeon complication rates. Also vis-a-vis, as the knowledge and the investigation modalities and skills and the diagnosis improves, we are extending our indications and more in the peripheral compartment, peritrochanteric and subgluteal space. However, when one ventures into a wide spectrum of indications, it's very important to make oneself aware of all the potential pitfalls that may occur throughout the entire procedure to try and minimize complications. So the areas of potential pitfalls could be either in decision making, which is pre-op evaluation and imaging, or it could be during the surgical procedure itself, or in the post-operative period. And let us look at each aspect. So when it comes to preoperative evaluation, as is highlighted in the earlier talks, it is very important, like any other joint assessment, to have a proper history, also rule out any familial causes, and also get into the details of the patient's symptoms. And importantly, be aware that there are other referred causes of pain in the hip, which could give to a false positive type of situation. Also, it's very important to differentiate from evaluation whether the pathology that we are suspecting is intra or extra-articular. And also for this reason, one needs to be aware that there are various other differential diagnoses for pain, which is predominantly referred to or suspected in the intra-articular region. Assessment of hip pathology is equally important, and like anything in medicine, it is very important to have a systematic and a stepwise approach which works for the individual. Also, accurate diagnosis and appropriately identified surgical indication is the most important step in assessment. And when one is suspecting intra-articular pathology, we need to listen to our patients who would present with symptoms relevant to this type of pathology. And it's also to be confirmed on the appropriate exam. So we are all familiar as to what would be the commonest encountered intra-articular and extra-articular pathologies, and these form the common working diagnosis in our practice. As far as imaging goes, it is very important to get and also interpret the right imaging, and also perform the appropriate and relevant measurements so that we can reach to some sort of confirmation of diagnosis. And needless to say, proper higher imaging in the form of high resolution MRI and CT scan for attention to bony detail, and in cases of trauma is mandatory. In dealing with hip pathology, diagnostic injections play a very important role. This is in situations when the exam and the imaging is unclear and we want to rule out whether there is an intra-articular pathology. Also, if there is a combined pathology, both intra and extra-articular, use of these diagnostic indications would help us determine what is the extent of one compared to the other in relation to the patient's complaints. We are all very familiar of the commonest indications for hip arthroscopy, but it's also vis-a-vis important, as Vijay mentioned in his presentation, to make sure that we choose our patient wisely. We are aware of factors that may technically preclude the procedure or compromise our clinical outcomes. So in-depth knowledge into any of these is very important. Moving on to the surgery-related complications. When it comes to intraoperative complications, it could be during portal placement, leading to an injury to the labrum or the articular cartilage, or it could be injury to the neurovascular structures, injury secondary to traction, inadequate osseous reshaping in an FAI type of surgery, chondral damage due to misplaced anchors, fluid extravasation due to either the positioning or the prolonged nature of the procedure, and also hypothermia because of the prolonged nature of the procedure. So let's look at each one of them in brief. Injury to the acetabular labrum is relatively common, and one needs to recognize that the superior and anterior superior labrum are at risk during the anterolateral portal placement. Also, anterior labrum is at risk during the anterior portal placement, especially in situations where the visualization is poor. And also, it is important to remember and recognize that the labrum would be hypertrophied in a dysplasia type of patient. Injury to the articular cartilage, typically to the femoral head, results from insufficient traction, and therefore it's very important to ensure that we have adequately distracted the joint on fluoroscopy, and if required, we can distend it further by normal saline distension. And if, however, we note that for some reason the joint is not adequately distracted, then one should move on to the peripheral compartment first to allow the placement of guide wire, and then subsequently go into the central compartment under direct vision. And this is an important aspect to remember and recognize in our practice. Injury to the neurovascular structures is also reported because the hip joint is surrounded by the neurovascular structures all around. And typically, portal placements could lead to common nerve injuries, which I have described earlier. But importantly, most nerve injuries in relation to hip arthroscopies have been reported secondary to prolonged traction. And also, in order to prevent an inadvertent injury, a proper surface marking is crucial. And like I mentioned in my first talk, one should just make a stab incision, which should not extend beyond the subcutaneous fat, because the lateral femoral cutaneous nerve, typically in relation to the anterior portal, lies at risk. Injuries secondary to traction are common, and there are two types. The distraction type are usually soft tissue injuries in association with a neuropraxia of the femoral sciatic or the peroneal nerve. And the treatment or the way to prevent this is to limit the traction forces to less than 50 pounds or 22.7 kilograms, and also to minimize the period of continuous traction to less than 2 hours. And as I mentioned earlier, that after the initial check, we need to release the traction when we prep and drape the part and then reapply it. And that would minimize the traction time. The second type of injury is a compression type due to the perineal post, which would lead to injury or neuropraxia of the pudendal nerve and pressure sores on the scrotum and the labia. And this is prevented by a generous padding of the post and also positioning it against the medial thigh in abduction to try and create an appropriate traction vector to minimize this type of traction injury. Inadequate osseous reshaping, typically in FAI surgery, is nowadays a recognized complication affecting outcomes, as you can see here. And one needs to be meticulous in doing this procedure in the peripheral compartment, because this seems to be the commonest indication for revision surgery, and therefore under fluoroscopy guidance, with maneuvering the extremity in different degrees of rotation, one needs to ensure that we have resected the cam lesion adequately, as seen here in this video. So it's also important to avoid this by understanding the pre-op deformity on imaging, plan it intraoperatively on fluoroscopy, and make sure that we have resected the bone adequately. Chondral damage due to misplaced anchors is also a known complication. This is a peak anchor which has come out through the cartilage, and it is important, like shoulder arthroscopy, that we place the anchors close to the rim, but it is also important to ensure that the trajectory is such that we don't end up damaging the cartilage or the joint. On the other hand, if we err too much on the side of caution and we place the anchors too far away from the cartilage, we can evert or medialize the labrum and thereby compromise its function, the suction seal effect. So therefore, it's important to also make sure in our practice that the anchors are not placed too close to the articular cartilage, thereby leading to an arthrogenic cartilage injury. And typically, the 1 o'clock position and the anterior and the mid-anterior portals are most commonly implicated. And the way to prevent this is to try and use portals like the Dalla portal, use short anchors, use a curved drill to get into that area, and also ensure that we have a safe trajectory before venturing into the steps of anchor insertion. Fluid extravasation is a serious complication typically seen with extracapsular procedures like the iliopsoas release, and also when one does large capsulotomies to do more extensive procedures which increase the surgical time. And the way to minimize this is to monitor the abdomen, the core body temperature regularly, to minimize the surgical time, and to keep the maximum inflow fluid pressure up to 50 millimeters. So start with a lower pressure in the initial phases, and then when we come to the crucial steps, if required, you can increase the pressure, but don't do it the other way around. Hypothermia is also a very worrying complication. It is defined as a decrease in core body temperature below 35 degrees. It alters the regeneration capacity and also increases the risk of infection, and also promotes bleeding by altering the platelet activity and the coagulation cascade. And this complication can be prevented by using a warm blanket and a warm irrigation fluid management during our procedure. Post-operatively, the complications in the early phase could be infection, deep vein thrombosis, or instability, or in the later situation, it could be avascular necrosis, adhesions, HO, femoral neck fracture, and trochanteric bursitis, so iliopsoas tendinitis. Just to talk you briefly through that. So infection is generally seen because of prolonged surgical time, and also in cases of diagnosing undefined pain following a total hip replacement because you're getting into a joint. So the treatment for this is antibiotic prophylaxis. Deep vein thrombosis, although the incidence is underreported or unrecognized, it is a worrying complication, and some sort of prophylaxis should be kept in mind based on patient risk factors, and also early mobilization wherever appropriate should be the rule. Instability generally occurs due to soft tissue laxity or inadequate bony cover. This is generally seen when one does an anterior capsulotomy or a capsulectomy, where the iliofemoral ligament is also excised, and one needs to ensure that we do capsular repair, and at the same time in bony procedures avoid excessive bony excision from the acetabular rim. Late complications like avascular necrosis are common with distraction, partial capsulectomy, and also because of the damage to the lateral epiphyseal branch of the medial femoral circumflex artery. So hence caution has to be exercised when one ventures into capsular dissection or bony resection posterior to the lateral synovial fold in the peripheral compartment. Adhesions are common after labral repair, rim resection, or osteoplasty, and if appropriate, post-op use of CPM or the stationary bicycle without resistance is advocated. HO is generally seen following FAI and large capsulotomies, and therefore at the end of the procedure, it's important to wash the joint thoroughly, consider some sort of prophylaxis, and suture large capsulotomies. And importantly, ensure that we follow up these patients at least up to a year to recognize and, if required, manage this complication timely. Femoral neck fracture is commonly seen after over-enthusiastic resection of a CAM type of an FAI. And generally, a way to prevent this is to ensure that we limit the weight bearing in the early post-operative period, handle the burr very gently, avoid bony indentations which may subsequently act as potential stress risers. Trochanteric bursitis and iliopsoas tendinitis are generally seen in patients with previous surgery. Dr. Prasad talked about children, complications in children are known. This is because of the smaller body side, variations in anatomy, and the possible history of previous operations. Also, they are at a higher risk of hypothermia. Careful positioning is crucial, and manual traction alone in very large children with dysplasia should be contemplated. And the portals may need to be modified accordingly in this type of patient profile. And also, sometimes smaller instrumentation would be a good way to prevent any iatrogenic injury. So in short, the way to minimize complications is to make sure that we have a relatively safe procedure. We recognize the potential complications and the ways to deal with it. It is important that we train ourselves adequately, do some hands-on training as well, and if necessary, get our mentor to supervise the first few procedures. A precise surgical technique, like any procedure, is important, with the right instrumentation to ensure that these complications are minimized. And also, complex cases should be discussed with senior colleagues or in a forum or a WhatsApp group which is existent with us. So in summary, hip arthroscopy overall is a safe procedure to approach the hip joint in a minimally invasive manner. It has revolutionized the treatment of many intra and extra-articular conditions. It is unfortunately highly operator dependent and certainly not without complications. And therefore, thorough knowledge, training, and experience is essential to ensure a good clinical and safe outcome in our patients. Thank you very much.
Thank you, Shreyas.
That concludes the meeting. Thank you.
Yes. Now we can take the questions. Some questions, if they are in the chat box or IPS. Have you got any questions on your YouTube there?
Thank you. We have some questions coming in. So maybe let's start with the first question, Shreyash. And you talked about portals. There is a question: how often do you use a zig to guide yourself for the second portal?
Good question. There are dedicated jigs from different companies, but obviously there is a cost involved, and one needs to recognize that hip arthroscopy indications, especially in India, are not very common. So, there is always a limited resources to purchase these instruments. So I really, generally speaking, do not use these kind of dedicated jigs. But certainly these jigs are meant to ensure safe portal placement and minimize complications.
Other question is to Dr. Munting, basically. The question essentially is, how do you evaluate that your decompression which you are doing when you do a labral resection first, and is it adequate, and you want to actually do more of excision of the pincer? So how exactly do you quantify your pincer excision?
Much like Prasad, I use a lot of, and in fact, all of you guys probably, I use a lot of fluoroscopy. So on-table fluoroscopy guides me in terms of the degree of resection needed. Okay. I always measure out my walls, if you will, with a little probe with 5mm laser lines. So I have a good guide as to the depth of the socket and how much I can resect. And then once I've done all that, we disconnect the foot from the traction table and actually mobilize. So I have this, it looks a bit awkward, but I have this leg over my shoulder just about, and we put the patient in deep flexion range and check what levels of impingement we've got. So you can do an on-table assessment and intraoperatively as to the adequacy of your resection. But I do a slight warning out there. Definitely, you can always resect more or come back again if you haven't done enough, but you can never put backbone. So I'm very careful with overdoing it, and it's very rare. I know that Prasad spoke about an 8mm depth resection. There are occasions when one has to do that when you've got a lot of calcified labrum literally, but it's very rare that I go much over 4mm. Because it seems to have there's some good literature which is indicating that there is a negative effect in terms of that hip's, taking into consideration the preoperative state of the hip and the evolution of that hip through the patient's life. If you resect a lot of cartilage on the acetabular side, you actually negatively affect the forces through the joint. Because there are these rare cases where one actually has a form of dysplasia where there's a massive fovea and actually not a lot of articular surface in the face of a relatively deep socket based on a center edge angle. So it's not all clear cut. And one has to use a little bit of common sense while you're operating and think about the case carefully. But a lot of fluoroscopy on table and actual measurements of my wall depths.
So do you take the foot out of your traction device and maybe move it dynamically also?
So I have just a plastic barrier that I put across with a sticky adhesive film. That's it. So one can easily get hold of the leg, and I have an assistant, or the company rep can sometimes do it. They hold the leg, and I demonstrate, and I tell them to move it up and down, and then I can check visually that I'm not impinging.
Other question to you is, how often have you find that there is a subtle FAI, but the patient actually presents with a traumatic labral lesion? So you are just dealing with the traumatic labral repair, or you are doing something to the subtle FAI which is underlying?
Yeah. So sometimes you can get normal radiology. So you get a normal X-ray. Patients had a traumatic fall or a dislocation, and you're going in with the view of just repairing the labrum. As I said, I use dynamic arthrography, so I'd actually do an arthrogram on table just before I start operating, and I move the hip around. If I find that there are, specifically if there's a cam type effect on that hip joint when I'm doing the arthrogram, I will then look very carefully to make sure I'm not missing a cam lesion, which I will address at the same time. Again, you will more often than not find some early chondral problems if there's a cam issue. But I'm not going to say do a deep rim resection in a patient with a traumatic labral tear if that's the case. I will just trim it down to a bleeding rim and leave it at that.
Okay, and I think Shreyash, you raised your hand. So you
just along the lines to Dr. Munting. What % of hips have FAI? So in your experience, in your patient population, what would be the incidence of FAI, be it asymptomatic?
I would say that, you see, it's a bit difficult for me to say because I don't see them unless they're symptomatic. But we do know that, you can have a 20 to 30% rate of asymptomatic FAI candidates. I often have patients with bilateral camming and only one side symptomatic. I would say that there's a unilateral presentation for cam impinges in probably 70 to 80% of my patients. So, and then it's a tough job for me to say, listen, the other hip I'm worried about, because when we do get in there, we often find that they actually have more damage. So the determination of what's symptomatic and what's not is tricky, and often we've discussed this in our meetings. But I would say that if you do an impingement test or a Faber test and there is pain or discomfort in a patient who's not complaining of pain in that hip and they've got a cam or at-risk hip, then I will push them towards considering surgery.
Dr. Prasad, do you have any comment on this?
Two things. One is about the rim trimming, how much rim trimming to take. There's a paper from Chris Larson who said that up to 3 millimeters is safe, and you take 5 or more, you're going to get instability. Not about CE angle, but what I look at is anterior coverage. I measure anterior coverage separately on the head, and I believe that 20% is ideal or healthy. So I will not resect where I'm going to go down below 20%. But I template it preoperatively on a good pelvis X-ray, because intraoperatively my fluoro may not be as accurate. So I measure how much I'm going to remove preoperatively, and also depends on how much range I need. My patient required a 25-degree improvement of range of motion, and that's arthroscopically possible only if I remove about 8 millimeters. I believe that somebody did a study and said every millimeter of rim you remove gives you 2 to 3 degrees of internal rotation. So I calculated about a 7-8 millimeter rim trimming to relieve his impingement completely. That's why I went for a 7 to 8 millimeter rim trimming. How do I find out intraoperatively? What I do is my bore is 5.5 millimeters, and I did not separate the cartilage from the labrum when I do the rim trimming. So it's like undercutting what Thane mentioned earlier. So I'm going to bone and see how much it measures against my 5.5 burr. That's been pretty useful for me. Then if it's a small rim resection, I won't bother resecting the cartilage, but in a big rim resection, I will remove that cartilage and then repair the labrum. So that's for the first point. There was a second issue I was going to mention. What did Thane talk about just now?
FAI.
Yeah, asymptomatic FAIs.
Asymptomatic FAI. Yeah. So for me, the numbers I know in the US are 90% of American football players have cam morphology. or some other impingement risk factors. So for me, none of those factors are diagnostic. An X-ray is an X-ray, and it's a normal variation unless the hip is stiff and painful. If this hip is not painful, I won't call it impingement. It's not impinging yet. They may have a risk. It's cam morphology, but not cam impingement. Then some of them are stiff and not painful. Those are the ones I really watch carefully. They're the stiff hips. They may get into trouble. And if my impingement sign is positive, that's symptomatic enough for me. If I flex in the Fader test and they have pain in the groin, that's labral damage already happening. Those patients, I'm pretty happy to recommend surgical treatment. So impingement risk factors are very high in active people. Even 70% of soccer players and 70% of tennis players have FII risk factors, but that's not a diagnosed impingement. There's a radiographic morphology that may cause impingement, but impingement is a clinical diagnosis. They have to have pain with my exam.
Yeah. Perfect. A question is there that a lot of articles are coming up with AVN, avascular necrosis. Is there a role of hip arthroscopy along with core decompression in AVN? That's the question which has come from.
So IPS, if I may just answer that.
Yeah, please.
So initially for the core decompression, I used to do it arthroscopy assisted.
Yeah.
The science behind it is that you don't perforate the femoral head, but you see the fluoroscopy is good enough. So really adding arthroscopy would increase the time of the procedure. So in terms of AVN, at least in my experience, it is not mandatory. Unless you're dealing with associated, say, debriding, or you're removing some loose cartilages, or you're dealing with some sort of, or suspecting a labral pathology. Otherwise, I would not use it.
So I have one specific indication for AVN, like the younger kid Perthes disease I showed you. So AVN, if the joint surface is preserved for some reason, some AVNs do. Younger people more than older people, the cartilage is well maintained, then obviously they'll develop some type of sphericity and cam impingement. That's when I do a cam dissection. And then occasionally, more like a diagnostic arthroscopy to make sure the cartilage is good enough for me to do an osteotomy in those patients. So only small indication for AVN.
What's the typical size of an anchor for adult labral fixation and for pediatric labral fixation?
So, okay, fine.
Anyone can take it.
That a company supplies to me is 1.9 millimeters. That's a knotted anchor. I prefer a knotless anchor. In most children, I can get knotless anchors, at least 2 between 12 and 3 o'clock. But if I'm coming to the rim where it's close to 12 and close to 3, the rim is pretty thin. So that's when I go for a 1.9 millimeter anchor. Otherwise, what happens is the anchor will fit in, but it may bulge out anteriorly and impinge on the psoas tendon. So I like to use a smaller anchor at 3 o'clock position. Otherwise, I can get a standard 2.9 anchor in all of the places.
Perfect. Is there a special pediatric traction device you use for your pediatric patients, or is it the same kind? Modified?
No, the kid is big enough to allow me to put traction on regular traction table. I use regular traction, but that septic arthritis I showed, I'm not putting them on any traction. I just pull on the leg a little bit to look inside the socket when I'm doing the washout, but they don't really need anything special. But the 7-year-old I showed, did arthroscopy, that is done on the standard traction table.
What we learned from you, Thane, is that in dysplasia, there is not too much of a role of hip arthroscopy, because essentially these are bony changes which are there, and just doing an arthroscopy probably will not help. Is that the conclusion?
Yeah, I think if you look at the literature, and my own experience is that you can manage the intraarticular problems with the arthroscopy. There's a particular damage pattern, and you use that procedure to assess your cartilage. So, but there is a lot of support for the fact that a lot of these changes can sort themselves out by reorientating the acetabulum, so that doing a scope it results in 2 possibilities. Obviously, if you don't deal with the bone side of things, it's going to fail again. So you have to do the PAO as well. So it's a staged procedure if you're going to do a scope in a developmental dysplastic patient. And the other thing is that doing a scope with a PAO, if you do a PAO, those patients often don't need arthroscopy. If you do a PAO and you overcorrect slightly, then you can do a secondary scope procedure to do a slight rim trimming in the front to accommodate if there's an impingement problem. So that's the other occasional indication. But generally speaking, if you don't deal with the socket side bone issues, doing arthroscopy in those cases will fail in the long term. So not a common indication.
Question to you, Shreyash. I mean, it has come from Indian perspective, and they say that the patients, they sit on the floor, sit cross-legged. So how successful is a surgery of hip impingement in patients which are going to go back and do some kind of abnormal mobility to the hip joints? Shreyash and maybe Vijay to the.
So that is the reason I asked Dr. Munting and Dr. Prasad on the incidents, because there is a clear evidence that certain genetic or cultural habits really may predispose or underdispose to that. So they do it. I think it does take a while. Young patients, for things like squatting, sitting on the floor, it takes 6 months at least for them to be symptom free. It is also very important to have a good rehab, which was one of my questions to the other faculty as to in their setup how much importance they play to rehab, because in our situations not everyone is a specialized physio following these type of procedures. So, and also there is an issue with patient compliance, be it cost or just be it discipline. So there are several limitations in that, but generally speaking, in the right indications, they would get back to those habits, but it can take up to 6 months to achieve that.
Perfect. Just a last question before we can sum up here. Is there a role of a diagnostic injection in the hip joint to be really sure that the pain is arising because of the hip pathology or maybe in extra-articular pathology? So do any of the faculty do a diagnostic hip injection and then proceed for surgery?
IPS?
Yeah.
Yes, Vijay.
I do it. I do it all the time.
Okay.
Before we do the arthroscopy, especially in our country, the numbers are not so big. So before you embark on this procedure, I do it all the time. I am aware that there are some studies showing that there is a possibility of a leak from intraarticular to extraarticular through the iliopsoas tendon, but that's some small risk you have to take. But I think this gives good information about whether it's a real intraarticular or extraarticular problem before you decide on the scopy procedure.
And just along the line,
just last question which has come up, how often, Dr. Thane, Dr. Prasad, have you actually converted a hip into a open safe surgical dislocation that you think that you might need to do it in FA?
So I've never gone from doing a scope and then deciding the scope's not going to manage and I need to go open. I generally make that decision preoperatively, and I would say that about 5% of my practice I would prefer an open procedure, and I'd have a long discussion with the patient in that regard.
Perfect.
Earlier arthroscopy practice, when I was not very good at hip scopes, I used to scope and do whatever I could do, close and then open them up. That's how I learned hip arthroscopy, from open to arthroscopy. Lately, I don't have to convert as much, but the most recent one I did about 6 months ago, patient was about 390 pounds, and I thought I can get away. I thought I have enough experience, and I put her on the fracture table, put my scope in. The scope barely reached her hip, right, with all the fat. And more importantly, I was able to get the instrument because I planned ahead of time. The leg would not stay in that boot. The shape of the foot is so bad that it just kept slipping off, and the leg was falling off. So I gave up and opened her up. So that's
perfect. That answers our question.
I would have decided to open it from the beginning.
So from the chats, which I'm getting no more questions here. Thank you, Shreyash. And if there is any other question from any of the faculty, we can just conclude then.
Shreyash. I just want to mention one thing. The generation of Indians who squatted all their life have less FAI, right? So hip arthritis is less common in my generation because we grew up squatting and sitting on the floor. And I think it's not a bad idea for children to sit on the floor and squat, to mold their head against the socket. To look at dysplastic hips, they have cam morphology. All the dysplastic hips will have cam morphology because they didn't have a chance to mold. So these generations, you guys don't squat as much and you probably have more FAI. FAI is not uncommon in India, it's less recognized. What I noticed in India is the preoperative tolerance for pain is much higher. The postoperative tolerance of pain is much lower in Indians compared to the people I treat in America. Pre-op, they say no pain at all when they're suffering. And post-op, every little thing hurts them.
The reason, Prasad, is that they want quick results. So which is why I said, they need to understand and have a dedicated physiotherapy, be patient to expect the outcome.
So I think, Shreyash, you can conclude.
Sorry, make a last comment. It's been an absolute pleasure chatting with you guys and being part of this. Prasad, I just want to say my discussion in and around the rim trimming thing was basically because I worried about those who are starting and not doing too much, but you're obviously someone who knows what he's doing, so that's a different story. The squatting side of the discussion is interesting, and I made this a question at the last issue meeting where I said, why don't those huge sumo wrestlers ever get FAI or hip problems? It's because of the way they move, and hence my video in terms of what natural movement for a hip is with deep flexion, which is that external rotation sort of maneuver with the knee slightly apart. I just wanted to ask a question. What is your guys' experience, or do you use hip arthroscopy ever to manage the large cold abscess type collections in the face of tuberculosis in the hip? And have you found a place for arthroscopies to manage those cases, to limit the bony damage together with the obvious chemotherapy that you give the medical treatment?
So Dr. Munting, if I may say that I work in a private setup, so with the better medical management, the incidence of patients who come to me are less. Generally, the ones I deal with in infection or inflammatory pathologies, loose bodies or synovectomies, PVNS and stuff. But the incidence of tuberculosis, at least in the patient group I see, is next to zero. So perhaps in a government setup, it would be a different situation.
Right. Yeah.
I don't know what Vijay and Prasad have to say on this.
I have no experience with TB. Never diagnosed anybody or treated anybody with TB so far.
We have it on occasion, and we found that if we debulk the cold abscess quite aggressively, then the joint destruction was far less. So we didn't just rely on medical treatment. We actually take them to theatre quite soon, and do an arthrotomy and wash them out. And I was thinking whether or not there's any experience doing this arthroscopically. It's difficult to do arthroscopic work for me in the State. I do a session a week to teach. But this is just something that we see on occasion, especially with our high HIV prevalence.
Just a question to Thane. Large diameter hips after a hip replacement, how often have you treated arthroscopically the SWAS impingement? Have you done a couple of cases?
The cases where I've had to manage post arthroplasty with psoas impingement are funny enough more the dysplastic hips because of I don't medialize my cup too much, and there's inevitably a little bit of anterior wall overlapping, and they get the psoas impingement. The cases with the other reported cases of psoas impingement were typically the Birmingham hip type things, the resurfacings. They had a large influence, and also that cup is a very sharp edge, and there's the odd occasion for that. And those are the sort of scenarios that I have with the psoas impingement post-hip arthroscopy.
Perfect. So I think it was wonderful having you guys speak and good interaction, and I think almost all the questions which came up were answered to the satisfaction of people. So if Samanta, if you can just maybe do a concluding remark and then we can say goodbye.
Yes.
Swarnednu, can I just, before you conclude?
Yes.
I would just like to take this opportunity to thank the entire faculty for giving their time, especially in this situation. And really, this just sets the ball rolling for hip preservation, and there's lots more to come, and hopefully we'll have much more opportunities. And also, finally, I'd like to thank the IAS team. Really, they're doing a wonderful job and working tirelessly. They are glued to the webinars one after the other. So hats off to you guys and keep up the good work.
Okay, thank you, Shreyas, for arranging this thing. I say a special thank to you and Vijay, and my special thank to Prasad and Dr. Thane. Prasad, probably you can remember the memories in Kolkata that time you did the live surgery with us. So thank you again. Thank you, Thane Munting, and thank the whole team. Thank you. Take care.
Bye-bye.
Thanks, guys.
Bye.
Thank you.
Take care.
Bye.